Okay, I'm starting the timer and here is the session. Tell me when to go next.
Okay, ma'am, next.
Yes, yes.
Next, ma'am.
Yes.
Okay.
Got it? Yes.
Yes, ma'am.
We still have 30 seconds. If you want, I can break it and we
Oh,
can begin.
okay.
All right. Okay, so if you have read and understood, kindly begin your session.
Okay. Hello, good morning.
Hello.
Good morning.
Good morning, doctor.
My name is Dr. Ishfaq. I'm one of the doctors here. Okay. Before proceeding, may I check your name and date of birth, please?
Yes, sure.
Okay.
I'm Linda Roberts, and I'm 45 years old.
Okay. Nice to meet you, Linda. Okay. So, can you please tell me what do you know so far about your condition and what seems to be the problem right now? How can I help?
Okay, so doctor, yesterday I came to this hospital with this severe tummy ache, and I even vomited a couple of times. So after that, the consultant asked me to get admitted, which I did, and then you ran some blood tests, and they told me that I have something called pancreatitis. I'm not sure.
Okay.
So, but
yes.
I've been feeling better. They've not given me anything to eat yet by mouth, and I'm feeling better now. And my pain has, is under control. So, I want to take leave today, please. I have an urgency, please.
Okay. I can understand your concern. Okay, let me summarize this thing for you, what you have. Okay, so you have a condition what we call acute pancreatitis. That means there is an organ present in our tummy that we call pancreas. It has been inflamed. Okay, that's causing your these symptoms. Okay,
Inflamed,
and we thought
doctor? Sorry.
Yeah, in swollen. Okay,
Swollen, yes.
Swollen. Yes, and we think the cause of we think the cause of that is due to your alcohol intake, the vodka you are taking on the regular basis. Okay, so we're definitely and
is it
as we
something
have
very
done some
serious? Is it something very serious? Because you see, I don't have any pain at the moment. I feel like I'm fit to be discharged.
I appreciate your concern. You are good at the moment. You don't feel any pain at the moment. That is a good thing. That is a good sign. But this condition needs to be monitored. We have to monitor the patient in these situations normally for more than 48 hours or 72 hours to decide whether they will be having any further attack of this or whether any complication arises out of this. So at the moment you are right, that's a good sign, but we want to keep you under observation for some more time, and we may need to run few more tests on you. So our opinion will be that you should be staying in the hospital only.
But you see, I'm feeling better. I want to go home. And doctor, you all have not started anything. You've not given me anything to eat. When do I start eating? I'm quite hungry.
Yes, right. You are right. Your concern is totally right. As we have done some investigations on you that are showing that you still have this the features in your blood tests we have done that is showing that you still are in the phase of this swollen pancreas as the condition I have told you, acute pancreatitis. Despite that you are not feeling any pain, you are feeling better, but your blood tests are not up to the mark. They are not within the normal limits, but they are improving, but not exactly the way they should be. So and the second concern was that you are nil per mouth from yesterday and we are giving you fluids only intravenously. So your concern is when you're going to have the food or whatever liquid to the mouth. Once we think that this attack of swollen pancreas has subsided and your blood tests came back negative, that we may need to repeat on you, and when we'll be sure that that uh, you can take the food. So that moment we'll decide. We'll definitely let you know when to start the food. And at the moment we are giving you fluids and the nutrition through the vein on your, as you can see on your dorsum of hand. The fluids are
On the
giving we
back
are
of
giving
the
you
hand.
the vein. Yes, yes, at the
Yes.
back of your hand.
It names few risk factors or risks by patient going home. So what can happen?
So if we will discharge you, if we will send you home at this moment, so few complications can arise, few untoward things can happen, like you can have recurrent episode of this acute pancreatitis which we have gone through. What is this? And
Severe
patient can
pain.
at times
Yes.
have, you can feel again pain. Patient can have, you can feel again pain. You can have fever. You can have vomiting. You can have the chest issues like coughing or difficulty breathing. Okay, so there's a possibility
But
these things
doctor,
can.
that means,
Mhm.
but
Okay.
you see, I have to really take a leave. I don't want to stay in the hospital. I'm feeling very depressed and frustrated already.
Okay, I understand. I appreciate your concern. Being in the hospital, staying in the hospital is definitely frustrating and cumbersome all the times. But we are only keeping the patients in the hospital when we think it's absolutely necessary and it's in the best interest of the patient. At those times only we keep the patient in the hospital to receive the treatment or to monitor them or to deliver some kind of treatment. Okay. So in your case,
Yes, I
your concern.
understand all your things, all your medical things. I'm understanding, but please,
Okay.
I have this interview which I must attend. So please, can I take the leave from the hospital now? Then
Okay, so before going to decide that, I again want to like discuss this thing because your health is your health is your primary priority. If
Good.
you will be okay, then you can think of other things later on. Don't you? Don't you want to be okay? Don't you want to be all right?
yes, I do.
Mm-hmm. That's the one. Do you want to get, if we will send you home and you had any complication like we discussed it, so and you become unwell at the moment, and if anything untoward happens and it will pose a threat to your life or
Very
so,
good.
at time it can. So at
Okay,
that time,
doctor,
yes.
I understand
Mm-hmm.
your thing, but
Yes.
despite this, I understood the risk that you have said, but I want to take the risk. I want to take the leave, and yes, I want to take the leave. And what can I do? I mean, is there
Tell about the phone.
anything that I
Yes.
could do? Perhaps if there is any risk that arises.
Okay, before that, can you please summarize the things I have told you regarding your condition, and if you'll go home and what if the complications arise? Can you please tell me?
Okay, so you told me that I'm suffering from something called a pancreatitis, where pancreas, a certain organ in my body, has swollen because of
Okay.
my alcoholic habits. That's what you've told me.
Okay. Yes.
So and you told me that you are going to keep me here for observation, and you're also going to
Yes.
run some more tests to see how my condition is improving, and that you will not
Yes.
give me food yet until my blood test reports return normal. But
Yes.
I've told you I have to take, it's an urgent basis, I have to take the discharge from the hospital. I understand the complications that you have explained to me, but I'm ready to take the risks for those.
Okay. Okay. This is we totally agree with you. I'm totally agreeing with you, and we respect every patient's decision, and so is yours. So before going to that, I'm going to tell you a few complications, few signs and symptoms that might be arising. That will be kind of warning sign you have to be aware of. Okay, if you will be feeling like severe pain abdomen, vomiting, fever, or short of breath, these will be the things you have to be aware. And if God forbid these things happen to you, you have to come back to us as soon as possible, or you can visit to the nearby hospital at that time. And before leaving, you have to sign a document in which we'll be stating the whole condition of you, the whole situation, like your present condition, the investigation we have done, the possible complications, and there we will also state that you will be fully responsible for the complications if someone arise. So you have to sign that as well.
And you leave your number
Okay,
with the nurse in case.
I will sign
Yes.
the paper.
Good.
Okay. Okay, thank you very much. Thank you very much for your time. So if is there anything else I can help you, please let me know. I will leave my number at the nursing counter. Please tell them, they will immediately call me. Okay.
Good.
All right. Okay. Thank you, doctor.
Good.
Okay. Thank you.
Thanks.
Thank you very much.
So,
Thank you,
how was
ma'am.
it? It wasn't the usual
It
station that
wasn't
we
easy,
face.
No.
ma'am.
No, that's why I told you yesterday. I'll test you. Did you feel nervous? How was your feeling? I thought you
I
felt
didn't.
confident when 30 seconds were left
Yes.
of the question. You said, "All right, it was good. It's okay. I can do it." So I felt good that okay, he's confident. And then when you were explaining, you were jumping to medical terms. That's what you have to
Just
practice.
one medical
Yes.
jargon I have used.
Yeah, dorsum of the hand and intravenous, and
Yes. Yes,
that's when
ma'am.
I felt okay. Maybe you are nervous. Maybe you are feeling
Yes, ma'am.
hesitant or reluctant in talking too much.
No, ma'am. I wasn't feeling nervous, but I was like, this happens at
No, but
times. But
that's what
I
we'll
was trying
practice.
to be. I was trying to
Tomorrow
be
again,
natural.
yes, I'll give you something different, which hasn't
Okay.
been practiced before, and we'll see how
Okay.
you practice, because then I'll give you 2 minutes. You can think and recapitulate yourself, and then we'll begin, because that's how we'll practice, and then you'll become perfect. All the things, how
Yeah.
you did the management, it was excellent. But sometimes, like when something like this comes and you have to convince the patient to stay, then name the complications that can arise, that can take place, and make the patient, like how you made the patient sum it up. You did it very good.
Mm-hmm.
You make the patient take the full responsibility even till death, when
Yes, ma'am.
patient wants to go, even mention complications taking them to the death even.
Yes,
So
ma'am.
patient, if anything happens, patient is responsible itself. And in all this discussion, you have taken extra 2 minutes.
Yes, ma'am. I have.
Overall, it was very good. Yes, even Dr. Suman Kumar is agreeing.
Thank you.
And yes,
Thank you. Thank you, ma'am.
yeah,
Thank you,
he
ma'am.
has passed this station, but with me it's not like I want you to be excellent, so in real exam scenarios you pass. So here you have to be like superb. Thank you, Dr.
Yes,
Usha.
ma'am.
Thank you, Dr. Ishfaq. Yes.
Thank you,
Anyone,
ma'am.
Dr.
Thank you, Dr. Shah.
Abhishek would want to say anything? Anyone else? Dr. Muhammad Al-Tahir?
No, ma'am, not anything from my side. It was great.
Okay, it was great. Yes, good. Right. Okay, I'm starting the timer.
Yeah, sure,
And
ma'am.
here is your question. Right, so if you have read and understood, kindly begin your examination.
Yeah, I'll enter the examiner hall and I'll wash my hand and don appropriate PPE if it is required. And after
Yes.
that, I'll introduce myself. I will first inspect the patient. If he's lying, if he's wearing any face mask, I will ask his permission to remove the face mask so that I can talk to him.
Okay.
After removing the face mask and the ventilation mask, actually I'll just introduce myself and I'll seek permission to examine like looking at his chest, feeling it, doing some special tests and tapping over it. If it is okay with him, I'll just take permission from him. After doing that, I'll just expose the patient chest and abdomen. After exposing patient chest and abdomen, as the patient is having severe pain right now, I want to assess the patient according to the CRIS protocol.
Very good.
So at first, I'll check the patient's airway by talking to the patient. If the patient is talking, then I'll just think that the airway is patent. I'll just keep the patient I'll put the patient on high flow oxygen reservoir face masks with later on. Yes, and after that, I'll check the breathing status. At first, I'll check patient's mouth to see any evidence of central cyanosis or not. After that, I'll check the tracheal position, it is centrally or not. I'll check also the respiratory movement by checking the chest expansion at the just below the nipple level. And after that, I will just quickly tap over the chest after seeking patient's permission, and I'll ask him if he's any severe pain. He can tell me at any moment. Then I will just tap over the supraclavicular area, infraclavicular area, and 3 to 4 intercostal spaces on both sides to see the percussion note is similar or not, if there is any dullness over there or not, if hyperresonant or not. And after that, I will also check the axillary area, like 3 to 4 intercostal spaces. And after doing the airway part, I'll just listen to the front of the chest, like in the supraclavicular area with the bell of the stethoscope, and following the infraclavicular intercostal space with the diaphragm of the stethoscope. I will measure if there is any equal air entry or not, and if there is any abnormal breath sound over there or not. And I will also check the axillary area of the patient. And then I'll ask the patient gently to sit so that I can check the back of the patient's chest. So then I'll do the inspection one at first in the back of the chest. Then I will do the palpation, like checking only the chest expansion or at the back. And then I'll do the percussion also at the back to see equally the node is equal or not, if there is hyperresonance or dullness over there or not. And then I will check the auscultation, if there is any abnormal breath sound or bilateral equal air entry or not. And then I will switch to circulation, and I'll ask the patient again to lie on the couch, and then I'll check the pallor at the eyes, and then I have already checked the oral cavity to see any evidence of dehydration over there, any evidence of central cyanosis over there. Then I'll check the jugular venous pressure, and then I'll quickly check the pulse of this patient, peripheral warmth of this patient, and also capillary refill time. After checking that, I will quickly switch over the heart auscultation of the precordial area in 4 different regions: mitral area, pulmonary region, tricuspid and aortic region, to look for if there is abnormality of the heart sound or if there is any murmur over there. After checking the circulatory status, I will just look for any disability over there by checking if the patient, I think the patient is alert as the patient was talking. So the patient is alert and oriented. After that, I will check the exposure. Like I want to check patient's dressing by removing the bandage over there, and if there is any drain over there or not, I'll also check that. I'll also check if there is any indwelling catheter, urinary catheter over there or not. And after that, I will also I'll just cover the patient, and I will also check patient's leg further if there is any evidence of ankle edema over there, and I'll check the patient's calf tenderness or swelling over there by asking the permission to the patient. If there is any severe pain over there, I'll just press gently over the calf muscle.
Good.
Yes, gently over the calf muscle. If there is any pain over there or swelling over there, I'll just notice that. Then I will cover the patient. I will thank the patient. I will wash my hand.
Very good.
And I'll face to my examiner to look for, can I please see the charts? Can I please do the relevant relevant history and do other systemic examination? And I can check the previous results that are also available to me. And after seeing the charts and everything,
Yes. Like what?
Yes, ma'am.
What would you look in the charts? What is the most
yes, in the charts, I will look for is any evidence of tachycardia. There may be hypotension or the patient may be normotensive. There may be increasing oxygen demand of this patient, decreasing due to decreased oxygen saturation. And I'll actually look for these parameters, and also I'll look relevant blood results are available or not, check the hemoglobin level. Also I'll check the infective markers like WBC count, CRP level for this patient, and also I'll check if there is any coagulation profile is already given for this patient or not, if there is the patient is on any blood thinners or not. I'll check that, and then according to the charts I'll just decide and plan.
Okay, good. You still have 2 seconds left.
Yeah.
Just a second. Yes, 2 seconds were left. Very good. Okay, now I would want you to tell me, how would you, what investigations would you arrange after you have looked through the chart to go ahead with your,
after seeing all the charts, I will just order for some inflammatory markers like full blood count, CRP level, if it is already done or not, electrolytes level, chest X-ray. Yes, ma'am. Chest X-ray, ABG, and also ECG. I will also do the serum creatinine level to because I have planned to do a CT pulmonary angiogram to look any evidence of wedge-shaped shadow or wedge-shaped film defect over the CT pulmonary angiogram or not. Then I'll also go for the ECG level if there is any right ventricular strain pattern over there or not. I'll also see the ABG level if there is any respiratory alkalosis over there or not, ma'am.
And D-dimer and ABG.
D-dimer FDP level, yes, ma'am. To see the evidence of DIC over there.
What should be the management of pulmonary embolism?
So management of pulmonary embolism, actually we can categorize it in 2 ways, like massive pulmonary embolism and non-massive pulmonary embolism. If the patient is having massive pulmonary embolism, we can assess that the patient becomes unstable, the hemodynamically unstable. So that patient will require urgent thrombolysis or embolectomy, and followed by low molecular weight heparin and bridging with warfarin therapy. And warfarin therapy. And if the patient is not having massive pulmonary embolism, like patient is hemodynamically stable, only the chest pain, we can go for the blood thinners first, like with low molecular weight heparin, bridging with warfarin or not. And we can closely monitor the action of heparin and warfarin by doing repeatedly the APTT and PT and INR levels.
All right, just suppose you're scrubbed and you're in theater, you are informed about this patient, what would your next step be?
I am unable to go to the patient urgently because it's a very critical situation. I'll just do a crash call or code orange for this patient, medical emergency.
Very good. Thank you. Excellent. Yes.
Thank you, ma'am.
Thank you. Feedback, please. Dr. Suman or Dr. Ishfaq.
Great, ma'am. He has covered everything, but in charts, like in every post-op patient, we have to look for the post-op pain medications, whether the patient has received adequate medication, or not. It can be the cause of shortness of pain.
Yeah. So shortness of breath could have also been because of pain.
Yes.
Yes.
Otherwise, everything is covered.
Everything is good. Yes, Dr.
Thank
Suman,
you.
do you have to say anything?
No, you did very good.
Yes.
Very well. But I think covered everything
Yes.
because there was no actual chart present, so
No, I
we
didn't
didn't see.
mention any, but I asked
Yes.
him what he would do
But
because this is
yeah.
what he is expected to do in this station.
Yes.
And I think they will show you something, maybe chest
Yeah,
X-ray
there
and
will be
ECG,
actual chart.
ABG. Yes, there will be. Good.
Yes.
Thank you. Should we move on?
Thank you, ma'am.
Yes. Dr.
Thank you,
Mohammed
ma'am.
Al-Tahir, thank you so much, Dr. Vishal. Dr. Mohammed Al-Tahir, yes.
Yes.
Yes, are you ready?
Hello, everyone.
Hello.
I'm ready.
Yes. Okay, I'm starting the timer. Right. If you're ready, I've started the timer and here is the question. Right, so if you have read and understood, kindly tell me what are the differentials that you will consider for this
This
patient?
is most likely squamous cell carcinoma. It can be
Okay.
also basal cell carcinoma.
Yes.
Or it can be malignant melanoma, or can be actinic keratosis,
Okay.
or keratocanceroma.
Yes. How would you differentiate? What are the difference between basal cell carcinoma and squamous cell carcinoma?
Basal cell carcinoma, this is appear as barely papule lesion, while squamous cell carcinoma as a scaly patch, which usually crust and bleed.
Yes.
Basal cell carcinoma, there's never metastasized or rarely metastasized, while
Yes.
squamous cell carcinoma can be metastasized.
Yes.
Basal cell carcinoma usually occupy the basement membrane, while
Okay.
squamous cell carcinoma occur in the outer layer.
Yes.
Basal cell carcinoma usually occur in sun-exposed area, while cell carcinoma can occur in any area of the body.
How would you explain about squamous cell carcinoma? What is the most preferable place or site for squamous cell carcinoma
It's
to
most
appear?
common in the head and neck.
Okay.
Most common appear in the head and neck and in the scalp, and also in
Yes.
the external surface of the forearm and
Yes.
in the lower lip. Occur in this patient.
Okay. All right. Can you tell me how would you make confirm your diagnosis?
Okay, after history and examination, I will
Yes.
take punch biopsy for this patient.
Okay. And what should be the, can you tell me what is the incidence of squamous cell carcinoma? How frequently it occurs?
Squamous cell carcinoma occur about 16%.
Yes.
All
Okay.
patients.
What should be the treatment of squamous cell carcinoma?
There can be conservative management. Patient should use of sunscreen block,
Yes.
and also there may be topical, and also wear long clothes with long sleeves. This is
Yes.
conservative, and avoid ultraviolet exposure.
Okay.
There can be medical treatment and topical retinoid or typical chemotherapy.
Yes.
Patient needs surgery which can excision with safety margin.
Yes.
We can do cryotherapy or electrodissection with cautery.
Being
Curettage and electrodissection.
yes, being considering it to be a carcinoma, it leads or becomes a leading cause of hypercoagulable state. So what would you advise this patient how to prevent deep vein thrombosis?
Okay, patient should use low molecular weight heparin
Right away,
or
should there be a conservative and invasive management? Or okay, how would
acute.
you yes,
Acute patient should go for low molecular weight heparin, or we can give any anticoagulant as warfarin for 6 months.
okay, how would you monitor how what dose patient should
And
be taking?
should do INR investigation
Yes,
such as the BT and ABTT.
yes. How would you monitor INR? At what level? At what values would you keep it?
Should be 0.2 to 3.
Okay. Yes. How frequently should patient come or should get INR checked?
I'm not sure, maybe every 3 months, 6 months.
Okay. What else can you offer this patient? Have you heard of catheter-directed thrombolysis? What is that?
Yes, for the DVT, we can use catheter-directed thrombolysis if the thrombus is less than 14 days.
Yes.
If it is more than 14 days, we can do tissue plasminin activator. This is 0.5 to 1 milligram for 72 hours, 6 hourly.
Yes.
We can use the superior vena cava filter if it's the failure of treatment or there is any contraindication.
Okay. What are the complications that one can expect with the use of spare vena cava filter?
I don't know.
Okay. Can you tell me what are the cytological and histological differences of squamous cell carcinoma?
Cytology, this is the study of the cell function and morphology,
Yes.
while histology is the study of the tissue architecture.
Yes. And in case of squamous cell carcinoma, how would it be?
I don't. But microscopically, there will be a range of differentiation from the well differentiated with extensive keratinization,
Yes.
and also can be poorly differentiated or anaplastic feature that can be this keratosis with single cell keratinization.
Okay. Can you tell me what would be apoptosis? Can you define the term apoptosis?
This is programmed cell death, which leads to
Okay.
damage of the cell.
Okay. What is necrosis?
Necrosis is the form of cell death,
Yes.
which can occur as due to infections or inflammation, and is independent of the energy.
Okay. Just suppose you have asked for a skin graft on this patient post-operatively and the graft fails. What might be the cause?
Can be due to wound infection.
Very good. What is the most common organism that
Staph
you
aureus.
expect? Okay. Can you tell me what there be the clinical features or symptoms if wound has MRSA, methicillin resistant staphylococcus aureus?
There can be redness and swelling,
Yes.
and there can be post discharge and inflammation and fever.
Okay. What should be the management of a patient who has MRSA infection, wound infection?
Firstly, I will do incision and drainage.
Yes.
Patient might need oral antibiotic
Very
such
good.
as tetracycline or
Yes.
linezolid.
Yes.
If the patient needs admission, I will give IV antibiotics such as lisinoid or clindamycin or vancomycin.
Yes.
Also, topical with immuroxine or chlorhexidine.
Yes. And what else would you advise the patient?
Daily wound care
Yes,
and dressing.
dressing daily. Yes, very good. Very good, excellent.
Thank you.
Yes, what are they writing? Anyone else want to give feedback to Dr. Mohammed? Yes, they are saying good, excellent, they are happy.